Welcome everyone to the Lightning Talks session number 2. And we have 5 great panelists here to talk very quickly about their excellent work and their contributions to the Odyssey collection of research this year. So let me quickly just introduce myself and plug my own interest. I'm Ben Martin. I'm a research associate at Johns Hopkins University, and this is my 3rd Odyssey Symposium, and I have restarted the early stage researchers working group with Harry Reyes and Shonak Chattopadhyay, and we would love for you guys to join us tomorrow at 10:30 to 12:30, so it's very short. If you're available during that time, come join us. And it's our kickoff for the early stage researchers working group. Whether you're early stage, which according to the NIH, I think if you're within 10 years of your terminal degree, so that's a lot of people. But also if you've been doing this for a long time, we'd love to welcome you and have you there so that we can coalesce around some of the newcomers in this community, of which there are many. So anyway, that's my plug, and I'm going to stop talking about my interests and turn it over to our first presenter, Linying Zhang from Washington University in St. Louis. So without further ado, Linying, come speak.
Hello, everyone. I'm very honored to be here today to share with you our project on causal inference with multimodal foundation models. Real-world health data include diverse data modalities. A clinical encounter can generate structured EHR data such as diagnosis and drugs, but it can also generate unstructured high-dimensional data such as medical images and clinical notes. And these different data modalities convey different piece of information about the patient's health and their healthcare process. So being able to leverage multimodal data I think is very important and a very promising area for us to advance health AI and health data science. The clinical use case that we focus on in the study is diabetic macular edema. This is a complication of diabetes, and this slide shows the difference between a retina of a normal eye versus the retina from patients with diabetic macular edema. And this is what it actually looks like in front of an ophthalmologist. They use an OCT machine to visualize the retina layer that's at the back of the eye. And this cross-sectional image shows also labels with different colors, the different biomarkers. These are the extra fluid pockets within the retina layer or underneath it that blocks the light passing through the retina, and that can cause blurry vision or vision loss. So luckily, there are effective medications for patients with DME and this class of drug called anti-VEGF injections. There are 3 variations of anti-VEGF injections, and one is not that frequently prescribed in healthcare, so in this study we focus on the 2 that are more common. So our research question is one drug, in this case aflibercept, more effective than bevacizumab in reducing vision loss? And this is clearly a causal question, although I cannot prove it to you here, but hopefully if you went to the POE tutorial yesterday or have been with the Odyssey community long enough, this question will turn as a clear causal question. So the reason that it really motivates us to study multimodal learning in causal inference is because we believe that incorporating multimodal data is important to further reduce the risk of unmeasured confounding bias. For example, in our clinical study, the biomarkers from the images could potentially induce different treatment choices, and these image-based biomarkers clearly affect the vision recovery for these patients. And these biomarkers are not recorded anywhere else in the structured EHR, so in this case, fail to adjust for these images could potentially lead to unmeasured confounding bias if this causal diagram structure actually holds. So these are the 2 modalities we include in our study, and OCT images and also tabular EHRs. The first step we do in this multimodal causal inference pipeline is to learn representations. All right, the tabular data disappears, but assume we capture that with the encoder. And then we also captured the OCT images with an image-based encoder. We concatenate the latent embeddings into one unified vector. And then in the second step, we perform treatment effect estimation. In this case, we fit 2 models, one propensity score model, one outcome model, and we use regularized regression in both as the architecture for both models due to the high dimensionality of the latent embedding. And then we use the estimated propensity scores and also the estimated potential outcomes in a doubly robust estimator called AIPW to form the final treatment effect estimate. So for the EHR encoder, it is locally trained variational autoencoder on our data set because there isn't a widely validated and adopted pre-trained model on EHRs. But for the image encoder, we did leverage what is available in the open source community. So in 2023, one foundation model was released in ophthalmology that includes two image modalities on about a million images. And then about a year later, another model came out called Vision FM that include 8 different image modalities and also 3 times larger the sample size. But both foundation models have only been tested in prediction tasks, and neither of them have been tested in doing causal inference. So we decided to compare both in our analysis. When we first applied the 2 foundation models to our OCT images, we'll look at the embeddings using t-SNE plot. And the color, it forms 2 clusters, and that is corresponded to which imaging device was used. So that's good that at least the embeddings capture the device information, but we hope that it captures more than just that, of course. So for our study design, we include both EHRs and OCTs from our local healthcare system database. We estimate the comparative effectiveness of these 2 drugs on a visual acuity outcome. That is whether the patient's vision improved by 2 lines or more within a 2-year follow-up time window. And we extract pretreatment features, both EHRs and OCTs within a 1-year pretreatment time window. And we use our multimodal pipeline to estimate the causal effect and produce a point estimate as well as a 95% confidence interval. So this is the main result from this study. From top to bottom are the different methods. So the bottom 2 are the multimodal methods. So they both, the estimates indicate that the 2 treatments are similar in the full cohort, that's the pink dots, but we also performed a stratified analysis in patients with worse vision, and it found that the aflibercept performed better significantly from one model and not that significantly from the other model. We would like to point out that though, the EHR-only model gives qualitatively the same conclusion about the treatment effectiveness in the sense that the 2 drugs perform similarly in the full cohort, but in the sub-cohort that aflibercept seems to perform better. Okay, so we'd like to know where this piece of evidence stand in the literature. So we compare that to a randomized controlled trial as the starting point. So this was a trial published 10 years ago. And we found essentially the same thing. In the full cohort, the drugs perform similarly, but in the sub-cohort, especially the worse vision cohort, aflibercept performs better. Of course, this is just the beginning of a very exciting and very big field, and there's a lot of more research that is currently ongoing. So I hope this talk motivates you to think about and see some promising results by leveraging foundation models in doing causal inference to improve the reliability of real-world evidence. And with that, I would like to thank my students and my collaborators. Thank you very much.